Hello everyone, my name is Brianna Kane and I am presenting a case study of a patient with vocal fold nodules. SG is a 25-year-old female teacher at an elementary school and has been teaching for 3 years. She was referred for voice therapy with a diagnosis of bilateral vocal fold nodules located in the middle of the membranous portion. SG was examined and referred for voice therapy by an otolaryngologist, an ENT, due to chronic soreness in her throat and neck pain that traveled up to her ears. SG also presents with asthma and chronic heartburn due to her excessive caffeine intake. She has complained of the discomfort in her throat for about 4 months. SG had previously taught kindergarten and currently teaches 3rd grade. She reported how she overuses her voice daily because her 3rd grade students have a difficult time following directions and staying on task. Another issue she reported was that there has been loud construction outside her classroom window since the beginning of September. SG has been performing with poor voice production and vocal misuse habits. Her students are very distracted by the noise and cannot hear her elicit instructions or hear her teach her lessons. In order to compensate for the loud noise, she is constantly raising her voice level throughout the day to gain her students' attention in the classroom. The strain of her voice, due to frequent hard movement of the vocal folds, had caused the development of bilateral vocal fold nodules. SG does not smoke or drink alcohol. However, her daily water intake is very low. She drinks 5 cups of coffee and 2 glasses of soda a day. SG takes medications such as an inhaler and steroids to treat her asthma condition, and she also takes antacids for her heartburn. She presented with voice characteristics such as hoarseness, breathiness, and vocal fatigue. She also expressed that her voice sounds clear in the morning, but it worsens as the day moves on, which had caused excessive throat clearing and moderate dysphonia. SG's oral mechanism presents within normal limits for speech production. She reported muscle tension within her neck, and she also reported having chronic dry mouth and dry throat, which causes her to excessively cough and clear her throat throughout the day. SG is moderately dysphonic. Her perceptual vocal quality is hoarse and rough. It is also breathy during speech production. She completed the Voice Handicap Index and the total score was a 20, which is below the average score of about a total of 62. SG completed an acoustic analysis and the acoustic values, which included the fundamental frequency of 188 Hz, was within the normal range. Additionally, the phonational range was 2 octaves, a maximum phonation time of 9 seconds, and an SC ratio of 2.0. The airflow measurement was 202 milliseconds, which is greater than those for normal speakers since the nodules hinder the vocal folds from adducting completely. SG's vocal folds were examined to view the symmetry and periodicity of the vocal folds. The video stroboscopy evaluated the function of the vocal folds and indicated that there was decreased amplitude and mucosal wave movement. Furthermore, the bilateral nodules caused reduced glottic closure, which created an hourglass shape. Next, we're going to talk about the diagnosis. SG had her vocal folds examined by an otolaryngologist. The laryngoscopy examination indicated that SG had bilateral vocal fold nodules. The vocal nodules were located in the middle of the membranous portion. The nodules were moderately sized and were treatable with voice therapy and did not require surgical removal. The therapy treatment included indirect and direct therapy techniques. The indirect therapy technique demanded that SG must improve her voice use habits and to increase her daily water intake to hydrate her vocal folds. SG was able to continue teaching as long as she decreased using a loud voice and used a bell to gain her students' attention. In addition, SG demonstrated her instructions to her students instead of dictating them with her voice. The direct technique included warm-up and yawn and sigh exercises. The exercises helped coordinate breathing and phonation to reduce vocal fold and laryngeal tension, to reduce the inflammation and nodules, and to improve overall vocal function. The sessions were twice a week, 45 minutes long for 10 weeks. As a result, SG reported that the therapy techniques eliminated the vocal fold nodules, the hoarse vocal quality, and the soreness in her throat. There was also complete glottic closure during speech production, which eliminated the hourglass shape of the glottis. Furthermore, her students liked the use of the bell and began to follow directions more frequent, which helped her maintain a normal vocal pitch.